Mixed Bag 1. So can we call upon the first presenter for today? Dr. Archana Gunabalan. Yeah. So you are presenting, your paper is a prospective study on complications of SICS in patients with pseudoexfoliation. Okay, please start.
Good morning. My topic is on a prospective study on complications of SICS in patients with pseudoexfoliation. There are no financial interest and there are no conflict of interest. Pseudoexfoliation syndrome is an age-associated systemic disorder characterized by abnormal production and turnover of extracellular matrix. It is characterized by deposition of extracellular fibrillary deposits in different ocular structures. Prevalence of pseudoexfoliation in South India is 3.8%. The aim of the study is to discuss about the surgical complications of small incision cataract surgery in patients with pseudoexfoliation. Ours is an hospital-based observational study. We enrolled 44 patients who had clinically diagnosed to be a case of pseudoexfoliation and cataract. Our study period is 4 months from June to September 2022. We excluded patients who had a previous history of trauma and a recent history of uveitis and those who do not have any cataract lens changes. All of the patients underwent slit lamp evaluation, gonioscopy, tonometry and dilated fundus examination. Preoperative workup were done and peribulbar block was given. Manual small incision cataract surgery with IOL implantation was performed. We noted down the surgical complications and complications during the postoperative period and analyzed the result. Among the 44 patients who were enrolled in the study, 16 were males and 28 were females. The mean age of the study group was 70.54 years. Mostly nuclear sclerosis was observed in 40 eyes and 77% had dense grades of cataract. Preoperatively, the intraoperative pressure was 14.8 mmHg and 91% of the patients had an intraocular pressure within the normal range. Complications were noted in 79% of the patients and intraoperative complications were noted in 68%. 26 patients had a pupillary dilation of less than 6 mm. Multiple sphincterotomy was done in 20 patients. Nearly 41% of the patients had intraoperative floppy iris syndrome. 2 patients had a PC rent and vitreous loss. For them, primary vitrectomy was done and iris claw lens implantation was done. During the postoperative period, we didn't notice any iris prolapse, hyphema, residual cortex. Transient corneal edema was noted in 31% of the patient, which resolved by the end of 1 month. Preoperative visual acuity for 73% of the patient was less than 660 and postoperative visual acuity was better than 612 in 38 patients. We conclude that an increased risk of complications were observed in pseudoexfoliation patient and floppy iris was mostly associated with pseudoexfoliation. Even though complications were encountered during surgery, the overall visual outcome was bettered in a pseudoexfoliation patient. These are my references. Thank you.
Thank you. So how did you use devices, pupillary expanders in these cases, or do you manage just without any device?
I didn't use any device.
So you know, in pseudoexfoliation, the pupil is known to be poorly dilating. So if the pupil is poorly dilating, it's obvious that you will subsequently get all these complications. You know, like you said, the nucleus was not being delivered properly, retained lens matter, and all the other subsequent complications. So if you had used some pupillary expanding device, maybe you would not have encountered those complications. Okay? Okay, thank you. Thank you. Next, I call upon Dr. Lavanya SR, who will be speaking on primary bony lesion of the orbit, ossifying fibroma. Dr. Lavanya.
Good morning, everyone. Today here I am here to present a primary bony lesion of an orbit. So the patient was a 28-year-old female patient homemaker presented with a gradually progressive swelling over the left brow area since 9 months, and it was causing mild drooping of the eyelid. More than drooping, a patient was concerned about cosmesis, and patient was worried in future the eyes might get affected. So she presented to us, and medical, family, psychosocial history was unremarkable, and there was no intervention done in the past for the same, and there was no recurrence of the disease before. And clinical findings, apart from swelling, patient had mild mechanical ptosis like grade 1, and her visual acuity was normal. Her ocular examination, systemic examination, including extraocular movements, everything was normal, and there was no proptosis or anything or enophthalmos. It comes when to describe the swelling, it was a well circumscribed swelling. It was hard, 1/2 centimeter, non-mobile, and it was adherent to the underlying bone. It under the overlying skin was normal. It was not adherent to the skin, and underlying conjunctiva was also not free. There was not even a congestion or a mild redness in the conjunctiva, and we couldn't insinuate the fingers in between the bone and the mass. So we did imaging. This was the CT brain and the orbit of the patient. So it showed a expansile lesion arising from the periorbital region of the left orbital superior margin, and it was seen extending till the orbital roof, but it was not entering anywhere. So inside the medullary cavity is normal, and the extracorneal and intracorneal compartments are normal. Intracranial compartment also, there was no invasion. So we can see in various views, axial view, sagittal view, and the coronal view. So this was the 3D construction of the same, showing a clear-cut swelling. It was giving a very good idea of to know before surgery, to plan the surgery. We can see the supraorbital vessels were well far away from the swelling. And this was the MRI of the same person, and we could see hypointense lesion in the T2 images, and blood reports, everything else was fine. So we were differential diagnosis. We thought of many lesions, either benign lesion or malignant lesion, and obviously fibroosseous lesions were also thought of, because it was very slow growing over a period of 9 months. Management, we counseled the patient regarding the possible diagnosis, the complication during surgery, and our option was only surgical management of the that is excision of the tumor, and taking for biopsy. So patient was taken under general anesthesia with all precautions, like we had kept the blood and other things ready. Incision was taken 1 centimeter above the supraorbital margin, and the orbicularis oculi muscle was separated. We exposed the bone, the periosteum, and the supraorbital vessels were also separated, and this was the mass. It was very fragile, and it finally after the removal of the mass, good hemostasis was achieved, and then subcuticular sutures were put. So this was the post-op picture with edema of the upper eyelid. So in the histopath report, diagnosis came as ossifying fibroma, and this was the higher magnification hematoxylin and eosin stain. It showed areas of calcification, the fibrous tissue and the myxoid tissue. In follow-up over 9 months, 1 year, patient is doing fine. There was no recurrence. So we thought of many diagnoses, and after this thing we came to ossifying fibroma, and patient didn't undergo any chemo or radiotherapy after that. So basically these are general slow growing benign tumors. It's a rare case, and usually have a good prognosis. It will have a good prognosis. Thank you.
Okay, nice case. I wanted to know, did you check for the ocular movements?
Yes, ma'am. It's
Okay,
normal.
we don't have any pictures of that, right? I think, yeah, so that is also important, you know, when in a case we have you to show the different ocular movements. And what about when you said there was mild ptosis in the beginning, and was the ptosis totally relieved after the patient was
Yes,
operated?
I showed the picture of.
Again, in that picture, since the patient is not looking in the primary gaze,
Actually, the
this-
patient
yeah.
has sent the photo. We didn't. The
no,
receipt.
that doesn't work. So
Yes.
because the patient is not looking in the primary gaze, so we cannot make out if the ptosis is relieved or not relieved. That way. Okay. Thank you.
Thank you.
What is the incidence of this lesion? How rare, how common or how rare is it?
Actually, it is common in other bones, ma'am. But for the frontal or orbital bones, it is very rare. Probably 20, 30, 35 cases have been reported worldwide.
So when you started off, you were saying it's intraosseous hemangioma in your previous.
Yeah, ma'am. That
why?
Radiologically they gave diagnosis as intraosseous hemangioma.
Okay.
But then histopathology, there was nothing to prove that it was a intraosseous hemangioma. So we had to conclude it as ossifying fibroma.
Okay.
Thank you.
Thank you. Okay, so the next person, the presenting author is Dr. Niral Hinsu. Dr. Niral Hinsu. Is he here? Next one. Okay, so next person, chief author is, no, the presenting author is Dr. Soumya Johari. Yeah. So your paper is the deceit of the white eye. Yeah, okay.
Good morning, everyone. I'm Dr. Soumya, and I'll be talking about my paper, The Deceit of the White Eye, which is about the case presentation of PHPV in a 9-year-old female patient. So it came something like this to OPD. One girl, 9-year-old, walked in with parents with complaint of right eye diminution of vision and outward deviation since 6 months. Insidious in onset, progressive, no history of redness, watering, discharge, photophobia, no history of ocular trauma, which is very important, or surgery, no history of diplopia, flashes, and floaters. Past history, nothing was significant. Birth history also was unremarkable. Mother did not have any significant events in the antenatal period. Even it was full-term normal vaginal delivery, and there was no history of NICU admissions for the baby. Developmental history and immunization history both were unremarkable and appropriate for the age. So based on the history, the differential diagnosis we could think of were traumatic cataract, which is very common, especially in kids, and unilateral leukocoria. Complicated cataract, retinoblastoma, not so much common in this age, but still a possibility. Persistent hyperplastic primary vitreous, Coats disease, and ocular toxoplasmosis. So general physical examination, patient was conscious, cooperative, moderate built, well nourished. Systemic examination was unremarkable. There were no murmurs, no adventitious respiratory sounds, no focal neurological deficits, and no organomegaly. Coming to ocular examination proper, I'll just come to the normal findings. So in ocular posture, we noted that right eye, there was 30 degree of exotropia. Right eye vision was counting finger at 1 meter, which there was no further improvement. Left eye was unremarkable. Vision was 6/9 parts and color vision was normal. In right eye, again the lens was cataractous with zonules and elongated ciliary processes. And on indirect ophthalmoscopy, the media was hazy due to the cataractous lens, but what we could see was normal ONH with tortuous vessels, and there was a whitish stalk inferiorly. Left eye, again, fundus was normal. So these are the findings preoperative. Right eye, there's anterior segment. I've pointed out the zonules, which are those whitish strands, and the elongated ciliary processes inferiorly. And on the IDEO, as I said, media was hazy, but you can vaguely make out that inferiorly there's a whitish stalk. So because she had exotropia, we did BSV tests, both of Bagolini and Worth's 4-dot test. They both were indicative of right eye suppression. So the imaging modalities that we used in this case, first was ASOCT, which is suggestive of anterior bowing of the iris with lens matter near the zonules. You can see those particulate points near the zonular area. In UBM, again, there were elongated ciliary processes and zonules. The B scan, so there was a stalk arising from the retina. However, it was not extending entirely anteriorly, and it was a few low to moderate reflective dot-like echos. So based on the above history and the findings, the patient was diagnosed with combined anterior and posterior PHPV, and was advised to undergo cataract extraction with IOL implantation. After obtaining due pediatric fitness and anesthetic fitness, the treatment was done under GA. So as you can see, it's like a partial cataract. Regular staining we did. However, the lens was stuck to the anterior capsule, so we had to do dissection with Warner's, and then after that, 3-piece IOL was implanted. Post-operatively, the immediate post-operative vision was 6 by 24 parts, improving to 624. And at 6 weeks post-op, the BCVA was 6 by 9 and executive D-type bifocal lenses were prescribed for the patient. So this is the post-op picture at 1 month. So PHPV is one of the most differential diagnoses of retinoblastoma. So these two are very different entities, and prompt diagnosis should be made, because if we discover it early intervention can be made and significant amblyopia can be prevented. Also, this was relatively milder, but in other sort of PHPVs, there can be glaucoma, like there can be secondary glaucoma, so if early intervention is done, that can also be prevented. Thus, in this case, because of the timely diagnosis, the vision and the joy of the girl was restored. Thank you.
So did you examine the fundus post-operatively? You haven't shown any fundus photo or your fundus findings, which is very significant.
Post-operatively, ma'am, again, the media was hazy, but the findings were
No,
similar.
why would the media be hazy? You can
Because
see a
there
nice
was,
opening in the capsule, so I'm sure you could.
CEO was there, so it was a bit difficult to capture.
Did you do you'd already done a PCC, right?
Yes, ma'am,
Yeah,
we
so
did.
then why would there be opacification? And we can see that opening in the capsule. Did you even attempt to see the fundus or
we
no?
We tried.
So there's nothing about the fundus. That is very significant. We would like to know how the macula is, whether there's any traction on the macula, what are the findings, because earlier you had a very hazy view. So the fundus should have been mentioned. That's that is a very, very big lacunae in your presentation. Okay, and did the child have microophthalmia as well?
No, ma'am. It was normal.
So it's a little unusual with PHPV to not
Yes.
to have microophthalmia, right?
Yes.
And why the deceit of the white eye? I mean, why this title?
Ma'am, usually when a child presents with uniocular cataract, we will usually assume that there's some trauma. Or,
A uniocular cataract is also congenital developmental. The eye is
Yes.
always white. So what was so deceitful about this? Again, your title is very inappropriate to what you have presented.
Oh.
You know, we were thinking that it's white, but there's something inflammatory inside or something that should be inflamed. But in a cataract, the eye is always white, right?
Yes.
Okay, thank you.
Okay, so the next presenting author will be Dr. Avitesh Kumar. Is he here? Next, then the presenting author is Dr. Dharamveer Chaudhary. Okay. Dr. Kumara Anusha. Are you okay? So yeah, okay. So you're presenting on eye donation, knowledge, awareness, willingness, and attitude among the most postgraduates in tertiary care hospitals. Okay.
Good morning, everyone. I'm Anusha. I'm here to present a topic on eye donation, knowledge, awareness, willingness, and attitude among the postgraduates in a tertiary care hospital under the guidance of Jyotirmay ma'am. Financial disclosure, no conflict of interest. Any profound decrease in the vision or blindness due to disease of the cornea is termed as corneal blindness, and the fourth most common cause of blindness all over the world. To combat this, corneal transplantation is very essential, and the number of corneal transplants is done is far less than the actual requirement in India. And this picture depicts India requires the eye banking, and the corneal transplantation is just very high. And the prevalence of corneal blindness worldwide is 12.7 million, and in India the unilateral cases are more than the bilateral cases. In the unilateral cases accounting for more than 6.8 million, and the bilateral accounting for 1 million, and in Andhra Pradesh the prevalence is about 0.56%. The current corneal procurement rate in India is about 49,000 per year, and we need 277 donor eyes to perform 1 lakh corneal transplants in a year in India. My aim of this study is to assess the awareness, knowledge, willingness of the eye donation among the postgraduates in a tertiary care hospital which is done in Andhra Medical College, Visakhapatnam. It's a prospective hospital-based study which is done for a period of 4 months, that is from May to August 2023, among 300 postgraduates in a tertiary care hospital. It's a self-designed, standardized, single response type questionnaire on eye donation awareness with a total of 18 questions, and the responses were collected through the Google survey forms and were entered into an Excel sheet, and finally the results were analyzed using SPSS software. My inclusion criteria included postgraduates working in a tertiary care hospital who are willing to participate in the study, and exclusion, those who are not willing to participate in the study, and ophthalmic postgraduates were excluded. And my questionnaire included the basic demographic details of the postgraduate and the questionnaire responses which included yes or no type with the following questionnaire. This is the questionnaire which I have circulated, and this is one of the response which is given by one of the postgraduates. And finally, coming to the results, coming to the demographic details, based upon the gender, the males are about 54% than the females, which is about 46%, and the second years responded better than the first, second years which is accounting for 62%, and the first years were 38%. And finally, the responses based upon the knowledge is, everyone had a pretty good responses on can eyes be donated, and the ideal time for the retrieval, and it does not delay the funeral process. And a mixed response has been shown in the 3 questionnaires. And finally, the responses based upon the awareness, it showed the one half showed a pretty good response, and the other half showed a mixed response. This is a response which is very good, and among this, the excellent one is, can a person wearing spectacles donate eyes, which accounted for about 98.8% saying yes. And the mixed response is shown in a person with history of medical illness like diabetes and hypertension can donate his or her eyes, and can eyes be donated if the one who pledges his or her eyes are blind. And finally, the responses on attitude and practice, and a majority have said that it is a service to mankind and it's not against religious belief, but 25% of the postgraduates are not willing to donate their eyes. The corneal transplantation offers the potential for sight restoration to those who are blind from the corneal diseases. This, however, is dependent on people willing to pledge their eyes for donation. In this study, the awareness was 93.25% and the willingness was 75%, but in a comparative study which was done by Singh MM et al. In 2007, the awareness was pretty good, high, that is 99.4%, and the willingness was 94.4%. And the less response compared to this study was done by Arya S et al. Study in 2004, in which awareness was 79.2% and willingness was 65.4%. And a gross difference has been shown in disfigurement of the face. In this study was 6%, and according to Bandari et al. Study, the disfigurement of face was 23.8%. And another gross difference which was noted was ideal time for the donation was 97%. And another study which was done by Daliwal U 2002 study, in which the ideal time for the donation was 63.3%. And finally, concluding, although overall knowledge regarding the eye donation among the participants was good, there were lacunae in the attitude, practice, and awareness among young healthcare professionals. So imparting them knowledge and educating the young healthcare professionals enable them to act as future motivators for enhancing eye donation and thereby reducing the prevalence of corneal blindness in India. These are my references. Thank you.
These comparative studies that you have mentioned, were they also done on postgraduates?
Among the
All
postgraduates,
the
medical
studies that you've mentioned, they were all done on medical students?
they are combined like postgraduates, medical students, that is interns, the paramedical staffs
But
also.
they were all done on medical, students or medical personnel.
yeah.
All those studies.
Majority
Can
of
you
the
just
studies,
go back to
ma'am.
the slides?
Yes, ma'am.
Because your study you cannot compare to a population-based study, A study of postgraduates has to be a study of, you've quoted a whole lot of studies. And I'm a little surprised that there are so many studies which have, taken medical students and, a similar kind of studies have been done. So that's what I wanted to just check. So all these studies, Singapore, these studies that you've mentioned, they were all done on medical students or
it
medical
included postgraduates, medical students, and the paramedic staffs, ma'am.
Okay,
most of
but
the
no one
studies.
took in consideration the general population.
General population was one study which was done in Singapore, in which those who are attending the OPD, ma'am, like the patient attendant among them. It was taken, ma'am.
So why did you carry out this study? What were you expecting to find in this study? I mean,
Actually, I
what
wanted
was
to
your
know the
yeah.
awareness and the willing, like how much the postgraduates would know, so that they can motivate the patients and the patient attendant after the death, like brainstem death patients, so that we can gain amount of the
Okay.
corneas which are required, ma'am.
So the awareness was pretty high, you said 93%.
93.25%.
But the willingness was 75%.
Only 75%, ma'am.
And then did you do something about it? I mean, the results of the study that you got, did you put into action, or you just did a survey and
I
what were
I
you,
did
what
a
was
survey, like in the individual responses, like are they able to, I mean, they're willing to donate eyes, or they were not willing to donate the eyes, that only I have taken, ma'am.
because this would have made, you know, a lot of sense if you had carried it forward or done something about it, and it would have been better if you had done it in the general population to see the awareness. See, medical people as it is are aware about it. The awareness is there with everyone. The willingness, yes, you said is less, but awareness is there. I mean, that's a taken, it's a granted thing. So the study would have, you know, been more useful if you had done it in the general population.
So you have the participants were the JR1s, the PG students,
Yes,
the MS
ma'am.
students, the first year and the second year, is it?
Yes, ma'am.
Yeah, and not again the third year. Okay. So and these students which you went to other you are from which place?
Here only, ma'am.
Here only,
Andhra.
Visakhapatnam. So did
Yes,
you
ma'am.
go to other medical colleges as well? I mean, how did you go to these people? I mean, what medical colleges have you taken around?
Andhra Medical College in Visakhapatnam.
So you
ma'am.
send these questionnaires to them,
Yes, ma'am.
yeah, through phone or something, or
Yes,
through
ma'am. Through the Google survey forms, ma'am.
Google survey form. That was a Google survey form. So you
Yes,
must have
ma'am.
sent through WhatsApp and then. Okay, fine.
Thank you. So next we have Dr. Ravi Kumar Bhukia, who will be, is he here, Dr. Ravi? Yeah, so he'll be speaking on the evaluation of bleb morphology among operated juvenile open angle glaucoma patients.
Good morning, one and all. Myself, Dr. Ravi Kumar, as a presenting author. Co-authors are Professor Ramajit Shiota and Professor Vinay Gupta. I am presenting evaluating bleb morphology among operated juvenile open angle glaucoma patient. So, as you know, juvenile open angle glaucoma affects mainly age group of 10 to 40 years and high IOP, that is more than 30 millimeter of mercury, and deep steep cupping with diffuse visual field defects, open angles on gonioscopy, and JOAG may differ from the other POAG. The former of more severe disease in the JOAG. So the long-term changes in the bleb morphology in the same patient at 1 month, that is good diffuse bleb, at 1 year, avascular, and 1.5 year, that is also avascular bleb, at 3 years, avascular and cystic bleb is there. So duration of the bleb increases as the changes is seen in the same patient of the trabeculectomy bleb. So in the same patient, either eye, one eye has cystic bleb, other eye has good diffuse bleb. So this difference we are seeing in same patient in operated JOAG patients. That's why this study has been done. The rationale of this study is juvenile open angle glaucoma patients undergoing trabeculectomy for IOP control need to live with bleb for a rest of their life, while avascular bleb is threat and fibrosed bleb is unwanted. In order to achieve the good ideal diffuse bleb, one needs to understand the factors leading to the achievement of the such bleb, such that these blebs may alter the preoperatively or intraoperatively or postoperatively. The objectives of the study is to evaluate the bleb morphology among operated juvenile open angle glaucoma patients to determine the factors affecting the bleb morphology in operated JOAG patients. The secondary outcome is IOP measurement. The inclusion criteria is primary open angle glaucoma with age of onset between 10 to 40 years, IOP more than 22, in one or both eyes on more than 2 occasions, open angles on gonioscopy, and glaucomatous optic neuropathy in one or both eyes with visual field defects, loss consistent with optic nerve damage. The exclusion criteria are history of steroid use, secondary glaucoma, patient not willing for give consent, patient in whom bleb photographs could not be taken. The methodology of the study is the sample size is 100 eyes of 100 patients in each patient at least 1 year ago operated. Then 20 eyes of 20 patients were evaluated prospectively over 1 year of the patient. Blood photographs were taken and graded. The methodology is blood photographs of JOG patients are evaluated by masked observer and graded using the simple classification and same magnification by us as classified avascular blebs, fibrosed bleb and good diffuse blebs. Bleb photographs were evaluated and correlated with following factors. The following factors are pre-surgical or pre-op factors: age at the time of surgery, gender, baseline IOP, duration of anti-glaucoma medication, and the size of the surgical factors like Tenon's thickness, use of mitomycin C 0.02%, size of scleral flap, size of ostium, and size of iridectomy. Post-op requirement of medications. These pictures showing the avascular bleb, and coming to the fibrosed bleb. This is the fibrosed bleb, and this is the good diffuse blebs. The surgical technique is fornix based superior localized peritomy was done, and one group is around 0.02% MMC subconjunctivally for 3 minutes and wash with saline, and other group is no MMC usage. The results, coming to the results, total number of patients are 142 patients and 122 patients in retrospective study and 20 patients in prospective study. Coming to the number of eyes, total number of eyes are 180, and retrospective study, total number of eyes are 160 and 20 eyes in prospective study. The bleb photographs available from retrospective study is 109 eyes, and bleb photographs available for all 20 prospective eyes. So the demographic data for all 142 patients at the age at the time of surgery is around 27 years, and more commonly seen in male patients, and baseline IOP is around 37, and duration of all medical treatments in months are around 53 months. So age at the time of surgeries, so it is usually most commonly seen around the age of 21 to 30 years of age group. Then coming to the bleb morphology. 109 eyes had their bleb photographed at 1 year among the retrospective arm of the study, and 20 eyes of prospective arm of the study using the same conditions and magnification. Blebs were classified by 2 independent masked observers. In cases that there is disparity in the classification, the cases were adjudicated by the 3rd observer. The bleb type and among MMC and non-MMC group, overall the bleb types are good diffuse blebs. And with MMC group and non-MMC group, there is not much difference, almost equal in both good diffuse blebs are equal in MMC and non-MMC groups. So now coming to the pre-op factors like pre-op IOP and duration of medications, that shows not significantly affecting the bleb morphology. Then coming to the intraoperative factors, what I told previously, none of these are affecting the bleb morphology at 1 year. The factors affecting bleb morphology at 12 months are nothing, none of these factors are affecting, and p-value is insignificant. The IOP profile over 1 year, the most of the patients having IOP around 7 to 18 millimeter of mercury at 1 month, 2 months, 3 months, 6 months and 1 year duration. The overall need of medication, around 80% of the patient at 1 year not required any anti-glaucoma medication in JOG patients after operating the patient. So absolute success rate as compared with MMC group, it is higher with non-MMC group. That indicates absolute success rate was with IOP control in MMC group is better than non-MMC group. The Kaplan-Meier survival curve, the IOP reduction 30% is better at 1 year as compared to the 50% of IOP reduction at 1 year. The limitations of the study are, large point of the study was retrospective and may have bias associate. The result of this study may are only 12 months, that is 1 year. The difference in the bleb morphology may be more apparent on longer follow-up. The post-operative factors like releasable sutures, timing at what time released, and the bleb massage, use of post-op steroids, presence or absence of bleb leaks, etc. were not evaluated in this study. And patient complaints which may be have reflected on the number of failures, those which qualified with success rate of the surgery. The conclusion is, bleb morphology among JOAG patient undergoing trabeculectomy is varied, though majority have good diffuse blebs. Preoperative and intraoperative factors analyzed in these studies does not seem to affect the blood morphology. At 1 year, absolute success rate was higher with use of MMC than the not using it. The recommendations of the studies, long-term studies recommended for further assess the factors affecting the blood morphology and post-operative factors, as I told you, like releasing suture, timing release, then blood massage, post-op steroids, like that have to evaluate. Use of low-dose MMC intraoperatively increase the absolute success rate without significantly affecting the blood morphology. Thank you.
I have a couple of questions.
Yes, ma'am.
So, a large number of patients in your study were in the retrospective
Yes.
arm. How did you analyze the intraoperative factors in these patients? If you go back to your slide, there are a whole lot of like Tennant's thickness.
Yes, yes.
Those you cannot, the OT notes are not going to be mentioning such detailed, things.
Yeah,
So how did
all
you
the
do
details
that?
have been mentioned in the OT notes, ma'am.
Can you just go back to that slide where you talked about it? So why was this done? Did you plan to do a prospective study? I mean, in the OT notes, why were these things mentioned? If you could go back to the slides. I'm quite amazed at the details of the OT notes. The slide where you, can you go back?
Yeah, yeah.
The surgical factors. Yes, this.
Yes, ma'am.
So all this was mentioned in the size of the osteum, size of iridectomy?
Yes, sir, these all cases are done by single surgeon.
Yes.
So they mentioned in all the OT notes.
So is this a normal protocol? Which center
Yeah,
was this, if I may
Epicenter,
ask?
ma'am.
So is this a normal protocol to
Yeah, yeah,
mention
yes,
for
ma'am.
all
Yes,
patients,
yes,
for
ma'am.
all
For all
surgery patients?
trabeculectomy patients.
Oh, okay. Not that you were thinking that there'll be a part of
No,
study.
no, ma'am.
So in a normal course, you
yes,
mention all these
yes.
details, which is very good.
Yes.
Okay.
Okay.
And did you try to correlate the bleb morphology with, like you said, a few patients required anti-glaucoma drugs even after that?
Yes.
So did you correlate the bleb morphology with how well the patients were controlled? Like which bleb gave a better control, which bleb required anti-glaucoma drugs to be added on?
That
Did
is
you do
not
any kind
evaluated,
of,
ma'am. That will be done for next follow-ups.
Okay.
Further.
And then you said that mitomycin worked better, but in one of your previous slides you said
Yes.
that the results were the same, they both gave a diffuse bleb.
Yes, ma'am.
So
That
what is the
morphology-
mechanism? Why would
Morphology
you-
among with mitomycin C and without mitomycin C almost
Almost the
good
same.
diffuse. But IOP control in mitomycin use is well controlled.
So what is your hypothesis? I mean, why would you think that this would happen?
So mitomycin might be more effective as not using it.
More?
Not using the
No.
mitomycin.
How would you postulate when the anatomy and morphology of the bleb is similar in both?
Yes.
Why is that group working better? Either we get a different morphology in both the groups, then we
Yes.
can say that one bleb is working better than the other. If morphologically the bleb is the same, then
Same.
why is the mitomycin C group working better?
It is not very much different, little bit different. That is around
No, is
around
it statist-
10%.
Because in the end, that is
Yes,
the major
yes,
outcome.
Yes,
Actually,
That
that
we-
is the major outcome of your
yes.
study.
Major
That,
yes. Yes.
So how do we apply it into clinical practice? Because at the end of this, we are all very confused. I mean,
Yes.
I'm confused
Yes.
that the blebs were similar in both.
Similar.
So and then the IOP control was better with mitomycin.
Yes.
That is what you're
Yes,
trying to
yes.
say. So I'm asking you, why do you feel this would have happened?
Might
You
be,
would have thought, right? Any imposture?
Yeah, I didn't thought, man.
You didn't think about it. Okay. Can you just go further to your conclusions?
Yes, ma'am.
Statistical data where you show that mitomycin C,
This one.
yeah, okay. So here you are showing that mitomycin C, the IOP control was better.
This red line is
despite
this
no
mitomycin
difference
C
in
group.
bleb.
Yeah, 16 18 millimeter of mercury around at 1 year duration. And this black line is no mitomycin group.
Okay.
What was the duration of anti-glaucoma drugs? You said they were on drugs,
1 year.
but these were juvenile patients, right? And
Yes.
they were operated, some of them at the age of 40, you mentioned.
No, age is around
If you go to your first slide, just go back to your first slide. First one. After this, yeah, just. Can we have this?
Can you maximize it? This is only the characteristic features of the JOAG patients, not for My
Okay.
paper patients are
Affects persons of age group 10 to 40.
40 years.
So, can you just define juvenile for the house for the benefit? Like what?
Juvenile it is early onset.
What age? Is there a criteria?
This is the mainly only after 10 age of 10 years.
Patients of 35 years,
Yes.
you categorize that person in a juvenile open-angle glaucoma or an adult?
It is patient might be based on these characteristics. Patient might be identified JOEG at 35 also, but it is started at early. That is around 10 years, 12 years, 15 years. So these all the features, that is high IOP, more than 30 millimeter of mercury, deep steep cupping with diffuse visual field defects, open angles on gonioscopy.
So these are the features of even a primary open angle glaucoma. How do you differentiate a juvenile open angle glaucoma from a primary open in an adult? That's what we're asking you.
This is the main age. Age factor is the main. That
So
is why
what
I
is that
mentioned
age? What is that age?
That before at the starting age is 10 years, ma'am.
Starting age is 10 years in a
years.
juvenile
Yeah,
case.
yeah.
And then here you say affects people of age group 10 to 40.
That is range
It
duration.
can go on.
Yeah.
Okay. All right.
I think if a patient of 30 or 35 years, if you include in your study, so I think that will be the history which will tell you if that the patient was having glaucoma for last 20 years. That is the only way you can make out, right?
History and examination findings we will correlate.
Examination findings पे कैसे पता चलेगा? How would you make a how would you make a difference from?
Yeah.
But
Yeah.
exam.
This is a yes.
This can be in an adult open angle glaucoma as well. Na?
Yeah, that is history also. Patient having
History all.
Yes.
That means that is only the history.
yes.
So for instance, if you get a patient of 38-year-old
Huh,
patient walking, so if you include in your study, if the patient gives you a history ki I have glaucoma for last 25 years,
Huh.
that is the only criteria, right?
That is history.
An examination it would remain the same.
Yes.
And how would you differentiate that adult glaucoma है का patient present कर रहा है,
Huh.
तो उसको तो नहीं differentiate कर सकते.
You can differentiate. Ma'am.
How? That's what is the question
Yeah.
is. That's
See, ma'am, JOG patient differ from adults on onset.
Yes,
POG,
tell
the
us that.
disease in the former is more severe consequent to the high IOP at the presentation and severe visual field loss.
Okay. All right. Thank you.
Thank you.
So next we have Dr. Anurag GV comparing autorefraction, retinoscopy, subjective verification and hypermetropes in an OPD setting.
Good morning, ma'am, chairperson. Good morning, co-chairperson. Good morning, colleagues and professors. My name is Dr. G.V. Anurag, and today I'll be presenting a paper that is comparison of autorefraction, cycloplegic autorefraction, retinoscopy, and subjective verification in hypermetropes in an OPD setting. Under the guidance of Dr. Prabhakar Shastri, sir. There are no financial disclosures and there is no conflict of interest in my study. So coming to the introduction, refractive errors or ametropias are anomalies of the optic state of the eye which cause an imperfect focus on the retina, which leads to a poor quality of the final image formed. Now, hypermetropia particularly is a refractive condition of the eye where parallel light rays coming from infinity are focused behind the neurosensory retina when accommodation is at rest. Cycloplegic retinoscopy and subjective verification remain the gold standard for measuring the refractive status here. It was seen in studies that in India, more than half a diopter of myopia or hypermetropia is seen in adults in almost 53.1%. And 10.2% of adults in India are estimated to have an uncorrected refractive error, which indicates a large burden of treatable disease. Excuse me. Coming to my aim, to compare autorefraction, cycloplegic autorefraction, and retinoscopy with subjective verification post-mydriatic in hyperopic patients. The objectives of my study are to compare cycloplegic autorefraction with autorefraction, to compare cycloplegic autorefraction with retinoscopy, and to compare cycloplegic autorefraction with the subjective verification for the best corrected visual acuity. My materials and methods, the study design is a cross-sectional observational study. My study design is a cross-sectional observational study. My study period was from May 2023 to August 2023. The study setting was OPD of the Department of Ophthalmology, Andhra Medical College, Visakhapatnam. And the study population were patient attending OPD with the refractive error of hypermetropia. This will be defined in the next slide. My sample size was 70 eyes of 35 patients examined. Now, the inclusion criteria: patients, parents, and guardians willing to give written informed consent, patients aged between 6 to 21 years, patients with hyperopia, that is hypermetropia, that is a initial AR value of more than half a diopter with a complaint of diminution of vision, or up to 0.5 diopters of or an AR value of up to 0.5 diopters with complaints of asthenopia. Now, exclusion criteria: patients with cylindrical errors of more than or greater than equal to 1 diopter of cylinder on autorefraction, patients with known ocular pathologies, patients with known history of contact lens use, and patients with any antecedent history of trauma, recent or remote. The autorefraction was done using Grand Seiko autorefractor GR3300K. The retinoscopy performed was done using a Heine beta 200 streak retinoscope. The cycloplegic used was homotropium 2% eye drops, instilled 2 times, 5 minutes apart. My methodology: for this study, 70 eyes and 35 willing patients were studied. Written informed consent from the patient, parent, and parent or guardian was obtained. Demographic data was collected. Uncorrected vision, slit lamp examination of anterior and posterior segment with +9 TD was performed. Next, routine AR and SV were performed, followed by cycloplegia, which was instilled followed by cycloplegia, which was done using homotropium 2%. Now, retinoscopy and cycloplegic AR are performed after about 1 hour. Now, in the next visit, that is 3 days later, subjective verification was done for the best corrected visual acuity. Data is collected from the patient documentation and tabulated in MS Excel. Data analysis: the data collected was tabulated and analyzed in Microsoft Excel and SPSS version 20 respectively. The paired t-testing was done to compare the data for the mentioned variables. Now, coming to my results, in my study, 70 eyes and 35 patients were included. Demographic details were studied, and they showed that the sex distribution has a slight male preponderance of 57%, whereas the female preponderance shows 43%. The age distribution showed that 20% of the patients are aged between 6 to 10 years. Majority, that is 48.5% of the patients are aged between 11 to 16 years, and 31.5% of my patients were aged 17 to 21 years, with a mean age of 13.5 years. Now, uncorrected visual acuity versus the best corrected visual acuity when they were leaving. 52% of patients showed less than 2-line improvement in best corrected visual acuity. 43% of patients showed more than 2-line improvement in best corrected visual acuity, whereas 5% of patients had an unchanged visual acuity, that is, they were not accepting glasses properly. Now, results. So, in my study, 70 eyes of 35 willing patients who met the inclusion criteria were studied. My results are as follows. When we compare cycloplegic autorefraction with autorefraction, a mean difference of 0.73 diopters plus minus 0.32 was seen to a p-value of 0.0049. On comparing cycloplegic autorefraction with retinoscopy, a mean difference of minus 0.49 diopters was seen, plus minus 0.38, with a p-value of 0.0083. On comparing cycloplegic autorefraction with subjective verification, the mean difference was seen to be 0.125 diopters plus minus 0.35 with a p-value of 0.65. The autorefraction additionally, when I compared autorefraction with subjective verification, the mean difference was seen to be minus 0.61 plus minus 0.45 d with a p-value of 0.02. So these are the graphs. This is the representative data, but these are the graphs for the above mentioned comparisons. So coming to my discussion, based on the results, I came to three inferences, which are: there is a significant difference in routine autorefraction and cycloplegic autorefraction that is being performed, and there is a significant difference in cycloplegic autorefraction and retinoscopy. Like, the data sets are not extremely similar, but when we are comparing cycloplegic autorefraction and subjective verification, the data was not statistically significant. That is, the mean differences were not a lot. The data sets were kind of similar. This implies that the difference between cycloplegic AR and subjective verification is statistically similar based on my study. Hence, refraction done under cycloplegia corresponds better to the actual hypermetropic error. Studies conducted by Uras et al., William C. et al., Hashemi et al., and Chung YF et al. Show findings that are concurrent with my study. Hashemi et al. Also observed that the spherical refraction results with autorefraction tend to be over plus in hyperopic cases, which is not seen to be concurrent in my study. This could be due to the age group differences or variation in accommodative ability of the patients. Now, Uras et al. Performed a study to assess the efficacy of autorefractors. It was observed in hypermetropes, sphere power was significantly lower in non-cycloplegic autorefraction than cycloplegic autorefraction and traditional retinoscopy. They concluded that the use of autorefractometers in children in whom accommodation is more active than older patients without cycloplegia may actually underestimate the error. William C. et al. Conducted a study to determine the accuracy of autorefractometers in a pediatric population. It found that autorefractometers underestimated hyperopic errors when used without cycloplegia. It was at least as good as a screening device as any other instrument, especially when judged by its ability to detect the anisometropia and because of the repeatability of the autorefractometer results. Now, in a study done by Hashemi et al., where a comparison of sphere and cylindrical refraction is done for retinoscopy and autorefractors.
These are the other studies, you know.
Yes,
so
yes,
you
ma'am.
need not tell in so detail what the other
Alright.
studies are. You just need to give the references. You can just conclude what you wanted to say.
So, coming to my conclusions, autorefraction is a quick, easy to perform and reliable method of refractive estimation for assessing large volumes of patient, which is pretty relevant in India. Cycloplegic autorefraction is better than routine for assessing refractive errors of hypermetropia. However, retinoscopy remains the gold standard for refractive assessment. Thank you, ma'am.
So, I mean, whatever you concluded is something different from what we already knew.
It's known facts, ma'am. Just
So,
population. So per se, most studies are done with myopics and hypermetropic. It's a blanket study. I wanted to particularly see what the inferences were in hypermetropic cases because we have excessive accommodation, lot of things
So
happening.
that's what we already know in hypermetropes. So even so, cycloplegic refraction is a must, and retinoscopy is a must in children.
Ma'am, but in
And,
our
and one more thing, what was your inclusion criteria? What is the range of hypermetropic refractive status you have
ma'am,
taken?
so patients
Just go back to that
yes, ma'am.
slide of inclusion criteria. Yeah.
So once patients presented to the OPD, we usually do a routine AR and then they come to us with the uncorrected vision. So
What is-
patients complaining of diminution of vision with more than 0.5 diopter on the AR, or patients who are not having who are having a plus 0 to plus 0.5 error, but they were not complaining of diminution of vision. They were having asthenopic symptoms like headaches, eye pain, etc.
So even even who were not complaining of diminution of vision, but when you did the visual acuity and you saw that there is, and you did the refraction,
Yes,
and
ma'am.
you find out it's plus 0.5,
Spherical error, ma'am.
even if the patient is not complaining with headache
Patient per se
and
doesn't
eye
think,
ache.
yes, ma'am. Patient per se thinks his vision is perfect.
Okay.
So why did you not include patients who had, there are many patients who are hypermetropics who do not have asthenopic symptoms, especially children. They adjust very well to that.
Ma'am,
We all have seen those patients, so you did not include those patients,
Ma'am,
right?
so my age criteria was 6 to 21 selection because I wanted them to be verbal and at least communicate effectively. And ma'am, the inclusion per se that the kids with excessive cycloplegics, I'm so sorry ma'am, could you just repeat the question once?
No, I said that even if the child has no diminution of vision and no asthenopia, you will still find a lot of them turn out to be hypermetropic.
Ma'am,
When you
but,
do a cycloplegic refraction,
Yes ma'am.
the child will come reading 6.6 with no complaints. But in children, because they have such a strong accommodation,
Stronger accommodation, smaller
Yes.
eyes as well ma'am.
yes,
So they're naturally
yeah,
hypermetropic.
so you could have included all children and then done the study and seen how many were hypermetropes, something like
Yes
that.
ma'am.
Another thing, in the end, you said that retinoscopy remains the gold standard, but in your slide, you said that retinoscopy had quite a bit of error as compared to the.
Ma'am, per se not an error. The data sets were different with a statistical significance. That means they're not identical. We cannot use them interchangeably.
Okay, so then how would you say that is the gold standard? What was there
That's
in your
a
study
known
to
fact.
indicate?
I mean, I'm
No,
sorry,
no.
ma'am, but that's a known
You
fact.
were
so I
trying to
think-
do the study
Yes,
so
ma'am.
that you could come to know something
Yes,
newer than what we already know.
Yes,
The
ma'am.
known facts were already there. Whatever your study has, concluded was already known to us. So you were trying to find something new, wasn't it? So in that, in the end, how did you say that retinoscopy remains the gold standard when the two were not correlating, right? So now how do you know which is the better one? Retinoscopy and your autoref, there was a significant
Yes, ma'am.
difference.
Ma'am,
So
we
then
will
how do you
compare it
say
to the
that
best
retinoscopy? So
Ma'am,
when you compared the best corrected, it corresponded with the retinoscopy.
Much better, ma'am.
That's not what
I-
your slide, just show me a slide.
The comparisons I have not.
No, it was
This
there in
is,
your slide, and you said that the best corrected acuity corresponded to the autoref readings. Did you not?
I have just compared them, ma'am.
Okay.
I will just show
All
that
right,
again,
okay,
ma'am.
no
once.
problem.
Excuse me.
That's okay, that's okay. I'll discuss
Thank you,
later with you. Okay, thank you.
Okay, so the next presenting author is Dr. Leshna Koparapu. Okay, so you are presenting evaluation of etiopathogenesis of optic disc edema patients attending ophthalmology OPD. Okay. Yeah.
Good morning, respected delegates. I'm Dr. Leshna, presenting a paper on evaluation of etiopathogenesis of optic disc edema in patients attending ophthalmology OPD. There is no financial conflict of interest. Optic disc edema can be unilateral or bilateral, and causes can be hereditary, inflammatory, ischemic, infiltrative, toxic, or compressive. Clinical evaluation and differentiating causes of optic disc edema is important to arrive at a correct diagnosis. The management and prognosis depends upon the etiopathogenesis of the disc edema. Early and prompt treatment of disc edema will prevent permanent irreversible blindness, which is caused due to optic atrophy. Bilateral optic disc edema could be papilledema, which may be life-threatening unless treated urgently by neurosurgeon in order to relieve the raised ICT and probable space-occupying lesion in the brain. My aims are to evaluate the causes of optic disc edema, age of presentation, sex preponderance, systemic associations, and the risk factors, and evaluation of disc edema using various imaging technologies. Evaluation of different etiological factors, which included like hereditary, inflammatory, infiltrative, ischemic, vascular, toxic, or ocular hypotony due to any other cause. Timely referral to the respective clinical departments like neurosurgery, medicine, endocrinology will prevent the visual morbidity and serious systemic complications. My sample size is 20, and all patients who visited ophthalmology OPD or referred from other departments or evaluated for optic disc edema in NRI Institute of Medical Sciences, Visakhapatnam. And inclusion criteria included children above the age of 10 years and adults below the age of 8 years, both males and females. And all cases of optic disc edema secondary to intracranial, systemic, and orbital causes are included. Myelinated nerve fibers, morning glory syndrome are excluded. All patients underwent a thorough, detailed history of presenting illness, medical evaluation, and a thorough ophthalmic examination, which included assessment of visual acuity using both Snellens unaided and aided, pupillary light reflex, both direct and indirect, color vision using Ishihara, and IOP recorded with GAT, B-scan biometry, slit lamp biomicroscopy, fundus evaluation, both direct and indirect, visual field analysis using visual field analyzer, OCT, ONH, RNFL analysis, blood pressure, blood investigations, which included CBP, blood sugar, lipid profile, all the neuroimaging whichever required, CT, MRI, brain, spine, all the angiography, MRA, CTA, cerebral angiography, carotid Doppler if required to evaluate blood flow dynamics, LP, CSF opening pressure, CSF analysis. All the data obtained that is organized in Excel sheets and evaluated using statistical analysis applying SPSS software version 2.1. Coming to the results, there is increased incidence of disc edema in the age group of 21 to 30 years, accounting for about 30%, followed by 31 to 40 years, accounting for about 25%. And coming to sex distribution, there is highest female preponderance, accounting for about 65% of cases in females and only 35% in males. Coming to the complaints, 25% of cases were asymptomatic at the time of presentation, which means you need to evaluate asymptomatic patients also for disc edema, and 25 patients presented with only diminution of vision, and 25% patients presented with diminution of vision along with orbital pain and headache. Coming to laterality, papilledema is seen with highest incidence, accounting for 60% of cases, and 30% of cases were seen bilateral disc edema due to some other causes, and 10% cases showed unilateral disc edema. Coming to etiopathogenesis in disc edema, IAH rules its way, accounting for about 55% of cases, followed by non-arteritic anterior ischemic optic neuropathy, accounting for 10% of cases, followed by disc edema secondary to grade 4 hypertensive retinopathy in 10% of cases. Other causes also included like intracranial space occupying lesions, systemic conditions like neurocystic causes, and metachromatic leukodystrophies, thrombosis with aneurysm in the IC, and uncontrolled diabetic mellitus. And association with cranial nerve palsies, 85% of cases had no involvement of any cranial nerve, while 10% of cases showed involvement of 6th cranial nerve with LR palsy, and only 5% of cases showed 3rd nerve involvement. And around 80% of cases showed good visual acuity within the range of 6.6 to 6.18, and 10% of cases showed between the range of 6.24 to 6/60, and 10% within the range of 5/60 to 3/60. Coming to color vision, 75% of cases showed normal color vision, while only 25% of cases showed color vision deficit. And pupil reactions, 75% had normal pupil changes, while only 20% of cases had sluggish reaction, and only 5% of cases showed RAPD defect. Coming to visual field changes, 60% of cases showed blind spot enlargement, and 35% cases were not cooperative, and 5% showed other defects apart from blind spot enlargement. Coming to the discussion, in my study, overall optic disc edema, bilateral presentation as papilledema, secondary to idiopathic intracranial hypertension is more common, accounting for 55%, especially in the age group of 21 to 30 years, which comes to 30%. My study is in concordance with the study that is run by Anil Parajoli at Koirol Alliance Center, Nepal, Kathmandu, and 80% of people had normal visual acuity, and 75% had normal color vision at the time of presentation. In my study, there is female sex preponderance accounting for 65%, which is similar again to the study done by Selma Urfagoli at Department of Ophthalmology, Turkey. Non-arteritic anti-ischemic optic neuropathy is a second most common cause of optic disc edema, constituting about 10%, similar to the study that is done by Ahmad Marwan Abdulaziz at Department of Ophthalmology, Malaysia. Conclusion, idiopathic intracranial hypertension is the most common cause of papilledema in young patients in the age group of 21 to 30 years. Careful history, general and complete ophthalmic evaluation with necessary investigations like CT, MRI, MRV, CSF opening pressure are mandatory in order to diagnose the patients with papilledema secondary to IIH. Accurate identification, prompt treatment, timely referral with appropriate imaging modalities will help us to avoid further compromise in visual function, as they are often asymptomatic with good visual acuity at presentation. These are my references. Thank you.
Thank you so much. We'll take the next speaker because we're running out of time.
Thank you.
Yeah. The next one is epidemiological patterns of uveitis in government medical colleges ophthalmology OPD. Presenting author is Dr. Sangam Gehlawat. Is he here? Next we have Dr. Mohammad Rukhsana, who will be speaking on the prevalence of primary glaucomas in patients attending the ophthalmology OPD.
Good morning, respected professors and my dear colleagues. I am Dr. Rukhsana. I am here to study on prevalence of primary glaucoma in patients attending ophthalmology OPD. I have no financial disclosure or conflicts of interest. Glaucoma is the second leading cause of blindness in the world and responsible for 10% blindness in the world. An estimated population of 67 million people are affected worldwide. Glaucoma is a progressive optic neuropathy with characteristic optic disc cupping and corresponding visual field defects with or without rise of intraocular pressure. The main aim is to evaluate different prevalence patterns of primary glaucomas in tertiary care hospital. This is a prospective case study and the sample size is 30. All patients underwent a comprehensive eye examination in a hospital which included visual acuity, slit lamp biomicroscopy, IOP measurement, gonioscopy, dilated fundus examination, and perimetry in selected cases using Humphrey Visual Field Analyzer. Inclusion criteria, all adults in the age group from 40 to 80 years were included in the study. Both male and female were included in the study. Exclusion criteria, all adults less than 40 years, more than 80 years were excluded. Patients uncooperative for diagnostic evaluation procedures were excluded. All secondary glaucomas were excluded. This is a demographic profile. The prevalence of primary glaucoma was more in the age group of 61 to 70 with prevalence rate 50%. And males are more commonly affected when compared to the females with prevalence rate 60% and 40% respectively. And 27% of people has hypertension as a risk factor. 40% of people has thin CCT as a risk factor. 23% of people has diabetes mellitus as a risk factor. And 10% of people have family history as a risk factor. So overall, thin CCT is a major risk factor for primary glaucomas in my study. Prevalence of vertical cup disc ratio in primary glaucomas. Greater than 0.6 cup disc ratio is seen in 87% of people and less than 0.6 is seen in 13% of people. Visual field changes. 40% people have superior arcade scotoma and 10% people have inferior arcade scotoma and 7% people have paracentral scotoma and 7% people have double arcade scotoma and remaining 36% patients are not cooperative. The prevalence of primary open angle glaucoma is more when compared to the PSCG with prevalence at 73%. A total of 30 individuals were examined. Mean age of patient was 40 to 80 years. POAG was found in 22 patients and PSEG was found in 8 patients. The prevalence of POAG was 73.4% and PSEG is 26.6%. The prevalence of glaucoma was significantly higher in men than women. The prevalence of glaucoma was highest among 61 to 80 years age group. In this study, hypertension, diabetes mellitus, family history and thin CCT were significant risk factors. Glaucoma usually asymptomatic. Patients often present late in the course of the disease with irreversible damage. According to Baltimore Eye Survey, prevalence of glaucoma increases with age. A positive correlation between glaucoma and diabetes was shown by Beaver Dam Eye Study, Los Angeles Latino Eye Study and Blue Mountain Eye Study. A positive correlation between glaucoma and hypertension was shown by Baltimore Eye Study. A positive correlation between family history and POIG was shown by Baltimore Eye Survey. These studies are in accordance with our present study. In this study, prevalence of POIG was 73.4% and PSEG was 26.6%. Conclusion. The prevalence of POIG was more than PSEG in this study. In this study, older age, history of hypertension, diabetes and family history and thin CCT were significant risk factors for POIG. As glaucoma results in irreversible damage, early diagnosis, evaluation of risk factors, prompt treatment and regular follow-ups are very important to prevent further damage. These are the references. Thank you.
Thank you. So did you find anything different in your study? I mean, which we already know about the prevalence of open angle glaucoma?
Actually, thin CCT, not much difference, ma'am.
The same?
Actually, same.
Okay, fine. Thank you. Okay, so the next presenting author is Dr. Chavan Pooja Vishnu. Yeah, okay. So you are presenting on the clinico-pathological study of benign and malignant eyelid tumors.
Good morning everyone. I am Dr. Pooja Chavan, presenting on clinico-pathological study of benign and malignant eyelid tumors. No financial interest. The eyelid tumor present a crucial aspect of in field of ophthalmology and most frequently encounter neoplasm in ophthalmic practice. These tumors were known to affect all the age group and gender and ethnic with the and ethnic background, and these encompass 90% of ocular tumor manifesting on the eyelids. The lead tumors are most prevalent neoplasm and this encompass diverse area of benign and malignant tumors. These are not only the source of aesthetic concern for the patient, but they pose diagnostic challenge for the primary care physician. The understanding the clinical and histopathological characteristic of eyelid tumor help in early diagnosis and management of the eyelid tumor. Aim of the study is to study the clinical profile and histopathological feature. The objective is to estimate incidence of eyelid tumor with respect to age and sex and to compare the clinical diagnosis with histopathological diagnosis. Inclusion criteria were both malignant and benign and malignant tumor based on clinical diagnosis which were subsequently confirmed through histopathological examination. Inflammatory lesion were excluded from the study. My study is prospective study done in the Government General Hospital of Kakinada over 30 patients over the period of 1 year. The primary source of data is clinical examination and medical records. Medical record include the patient's medical history, clinical presentation, diagnostic test and pathological report. The pathological specimen played a crucial role for confirming diagnosis and studying the histopathological feature. The mean age of presentation for benign tumor was 47 years and malignant tumor was 62 years. Male predominated were the female, and 60% patient had mass lesion over the upper lid followed by lower lid and medial and lateral catheters involvement. 25% cases showed lid margin involvement. The clinical presentation of eyelid swelling, the most common clinical presentation was eyelid swelling followed by ulceration. Total the most common benign tumor was seborrheic keratosis and most common malignant tumor was basal cell carcinoma. Benign tumor were mostly well differentiated, while malignant tumor showed a mixture of well differentiated to moderately differentiated pattern. Our study was in our study malignancy rate was 40% with BCC being most common malignancy and male predominance over the female. Intraocular invasion and metastasis was rare, but orbital involvement were seen in few cases. Our study was mostly similar to other studies, but Depres and Rajendra Kumar studies showed the sebaceous cell carcinoma being the most common malignancy. This study is comprehensive clinico-pathological study of benign and malignant tumor. Benign tumor were more malignant, were more common, and age distribution varied between the two age group. Basal cell carcinoma was prevalent malignant tumor, while squamous cell papilloma was most common benign tumor. The upper lid lesion were more common compared to lower lesion, medial canthus and lateral canthus involvement and lid margin involvement. And this study emphasizes importance of accurate diagnosis and histopathological evaluation for appropriate management.
Histopathological diagnosis you did, I mean, did you mention them in your slides? And what did you do? I mean,
no, I took help of pathology department.
So did you do excision biopsies
Yes,
and all
ma'am.
for all of them?
Yes, ma'am.
At your at your medical
OT.
college only, in
Yes,
the
ma'am.
pathology department?
Yes, ma'am.
Okay, fine.
Okay, thank you. So with that, we come to the conclusion of this free paper session, which was a mixed bag session. Thanks to all the presenters for all their presentations, and I hand over the hall to the chairpersons of the next session. Thank you. Thank you, everyone.